On behalf of Raaonline, my warm wishes to everyone. The topic for today's discussion is an important and significant condition, but an often overlooked one in the field of anesthesiology, that is diastolic dysfunction and its impact on the perioperative management, along with its consideration. Dear friends, I am sure all of you will accept with me when I say the core component of our preoperative evaluation is the cardiac evaluation. When we talk about cardiac evaluation, usually we concentrate on or which we give much importance to two important aspects. But one is the analysis or identification of valvular pathology. The other one is assessment of the LV function. Having said that, even though the LV function has got both systolic and diastolic, much of the importance and much of the significance has been given to systolic function alone. That's because systolic function has got some quantifiable parameters, performance indicator like ejection fraction, whereas not much importance has been given to diastolic function. So today's aim is to discuss about the importance of diastolic function and dysfunction and the impact of diastolic dysfunction in the perioperative period. So with that aim, our objectives will be, the first we'll start the discussion with analyzing the diastolic period, what are all the different phases, what do you mean by diastology, and how the diastolic dysfunction differs from the normal diastolic function, what is the prevalence at present, what is the pathophysiology of diastolic dysfunction, and how to assess, how to diagnose, and how to grade different grading systems, and what are all the perioperative concerns when you are dealing with a patient coming with a diastolic dysfunction, and finally the management. To start with, what is the definition of diastology? When we talk about diastology, what exactly you mean by diastology? It is nothing but an evaluation of diastolic function. Basically, we want to know how compliant the left ventricle is. That's what is diastology. My second question is, when I said it is often overlooked, why? That is because systolic function has got some quantifiable parameters which is easy to measure, whereas diastolic function doesn't have such parameter. That's number one. And that is number two is, most of these patients are asymptomatic at rest. They do not have any specific clinical symptomatology pertaining to diastolic dysfunction. The third important thing is why we need to assess the diastolic function preoperatively. This is where I am sure that you all know what is this, the basic physics behind this bow and arrow. So this diastolic function is basic determinant of the systolic function, just like how the string works or how important is the string for generating the force to deliver the arrow. The same way, diastolic function is the major determinant of its systolic function. So unless diastolic function is properly maintained, the systolic function will ultimately start declining. And when I said most of these patients are asymptomatic, they are asymptomatic at rest, but whenever they are exposed to some stressful condition, this diastolic dysfunction will get unmasked and it will be leading to diastolic heart failure. And moreover, this diastolic dysfunction per se is considered as an independent predictor of mortality as well as morbidity. So basically, this diastole is not a simple interval between two systolic period, but an active one. So let's start with understanding what does the cardiac cycle would mean. So this is an echocardiogram image, or rather the video taken during the one full cardiac cycle. So just to start with, to identify the parts, this is it's called Plaque's view. So this is the left atrium and this is the left ventricle cavity and this is the mitral valve and this is the aortic valve. So with this, I'll just run the video. So what you have to note is the constantly, so this is the left atrium. The left atrium, whenever the mitral valve is open, the flow happens across the mitral valve, then LV, left ventricle, during the contraction systolic period, it pushes the blood into the aorta through this aortic valve. This we all know. So when we dissect this part into multiple segments, we will see the difference between systole and diastole. To start with, this is the area, this is a time where both the aortic valve as well as the mitral valve is closed. And you see the LA is full and the LV is empty. That means the LV is ready for receiving the blood from the left atrium. So once the mitral valve opens, blood starts flowing. And then once the LV is full, now it is ready for the systolic period. So this entire period is the diastolic period. Then once it is done, the ejection starts, aortic valve opens, ejection starts, and it's end of the systolic period. So today we are going to discuss about the problems and other issues that is going to happen in this diastolic period. Okay. So as we all know, whenever volume is going to change, the pressure also will get changed. So in the same manner, if you construct this pressure volume loop, when the LV is receiving the blood, what is the pressure change that is going to happen inside? So we get this pressure volume loop. That is, volume is plotted in the x-axis and the pressure is plotted in the y-axis. So this pressure volume loop has got multiple points. Let me start with the one. The starting point is the point A, where the mitral valve is closed. So that is the end diastolic period. So once it is done, this is the period of isovolumetric contraction, where there is going to be an increase in the pressure without any change in the volume. So B is the point where aortic valve opens, then ejection happens. C is the point where aortic valve is closed, then there is going to be an isovolumetric relaxation, and D is a place that where mitral valve opens and filling starts again. So if you understand these very points, you will know the point between A and C represent the systolic period, and distance between or the point between the C and through D represents diastolic period. So mechanical diastole lasts between the closure of the aortic valve and to the closure of the mitral valve. Okay. So but in fact, the recent advances through which we have understood that even though classical teaching says the diastole starts from the closure of the aortic valve, that is immediately after the systolic period, the present advances or present understanding tells us that the diastole at the molecular level starts much before. That is, whenever the dissociation of the actin-myosin cross bridges starts, and that is the time where the diastolic period, true diastolic period starts. That means in the late systolic period itself, the diastolic period starts. So what are all the different phases of diastole? So as I already mentioned, there are 4 different phases. Starting with isovolumetric relaxation, that is C to B, C to D. There is no change in the volume, but there is a reduction in the pressure. So what exactly it means? Basically, because of this rapid reduction in the left ventricular pressure, without change in the volume, it produces a negative effect. That is, it's ready to suck the blood once the mitral valve opens. So the second phase is the early filling. That starts when the mitral valve opens. That's the point at D. So once the mitral valve is open, because of the increased transmitral pressure gradient across the mitral valve, there's going to be a gush of blood. That's called rapid filling or early filling. Then after a period, short period, once the early filling is over, there is going to be a small lull period where there is no filling or the filling is very, very low. It's called slow filling. Then finally is a late filling, which is constituted or which is determined by the atrial contraction, which is called as atrial kick. So when you draw it in a systematic manner, it's a schematic representation. So these two represent the systolic period, and this is the period of aortic valve closure, and this is the period of mitral valve closure. The duration between this represents the diastole. This period is the isovolumetric relaxation, and this is the early filling, and there is the diastasis period where there is going to be a very low filling, and this is going to be the atrial contraction. But how much blood is ejected or pushed into the left ventricle in each period? So majority of the blood, that is about nearly 70% of the blood, is ejected through this early filling. Then the diastasis, that period of the mid diastole, contributes about only 5%, and the atrial contraction or the atrial kick contributes about 25% of the blood. So okay, so what happens at the molecular level? We know the diastole, basically it is nothing but return of the sarcomere to its resting length. So how it happens? So contraction happens whenever this actin-myosin cross bridges contract, and relaxation happens, or the diastole happens, whenever this cross bridges getting released. So how it happens? So basically whenever for this relaxation to happen, this intracellular calcium level has to come down. For this intracellular calcium level to come down, there are so many steps will take place. To start with, this calcium should get released from the troponin C, and there is going to be extrusion of calcium through this sodium calcium pump, as well as calcium sequestration into the sarcoplasmic reticulum by a SERCA, that is C ATPase pump. And all these steps starts with phosphorylation of the phospholump bond. This is the initial step to start reducing the calcium, intracellular calcium level, ultimately end up in detachment of the actin and myosin cross bridges. Apart from the intracellular calcium level, there is another sarcomere protein called titin plays a very important role in diastolic period. So what is the role of this titin? It has got two important functions. Number one, this during the contraction, that is when the actin and myosin bridge is in the contracted states, this titin acts like a spring. It gets compressed, and during this compressed state, it reduces the or desensitizes the actin myosin complex to calcium. As a result, the actin myosin starts getting relaxed. But at the same time, once this actin myosin cross bridges start getting relaxed, this titin plays like a recoiled spring. Because of this recoiling effect, it generates a huge negative pressure, and it makes the LV ready to suck the blood across the mitral valve. So these are the two important points to be remembered as the important role of titin plays in the diastolic period. So to summarize, diastole is an energy consuming process, and any type of insult leading to ischemia and diminished adenosine triphosphate formation can disrupt this process, which leads to diastolic dysfunction. So having understood the different components or how the diastolic function or diastolic phase works, now we need to know what exactly causes the blood flow across the mitral valve. So the flow from the left atrium to left ventricle is dependent on the pressure difference between the left atrium and left ventricle. This pressure difference is determined by the lucitrophic properties of the left ventricle, that is basically how much is the compliance of the LV. This determines how actively the LV relaxes, and also it depends upon how effectively atrium contracts and contributes to the flow from LA to LV. So having said that, we have understood diastolic function is a energy consuming process, and it is a phase of active relaxation and passive filling. So to allow the left ventricle to fill and accommodate venous return without a significant increase in the LV pressure, you need to have normal diastolic function. Basically, the LV fills at low atrial pressures, whereas if there is going to be any change or any abnormality in the relaxation or in the filling, it's going to be called as diastolic dysfunction. Basically, its inability to fill at lower filling pressure is what defines diastolic dysfunction. Okay. So whenever there is an abnormality in diastolic distensibility, diastolic dysfunction happens. It's because of the problem happens either in the active relaxation phase or it is in the passive filling phase. But what we need to understand is, it is regardless of patient symptomatology or systolic function. That is, the patient can or may not have any symptoms, or the patient's systolic function will be normal or abnormal. This is what defines the diastolic dysfunction. Then, what is the difference between diastolic heart failure and diastolic dysfunction? Whenever a diastolic dysfunction patient starts developing clinical symptomatology, mainly of effort intolerance and dyspnea or signs of pulmonary congestion, these type of thing called anginal equivalence, you can say that the patient is going to diastolic heart failure. What about the systolic function? This is called heart function with preserved ejection fraction. That means only in the presence of only diastolic heart failure, they can have a normal or near normal systolic function. It has been found that recently the diastolic dysfunction is the major cause for diastolic heart failure. Okay. So what are all the available information on the prevalence? Is it very common now? Yes. The recent researchers have findings have clearly mentioned, or clearly we can come to know that it is on the rise. The diastolic dysfunction is becoming more prevalent and it's going to be a major perioperative concern for us. And not only that, the impact it's going to have on mortality is going to be very high. So basically, we need to understand that we are going to increasingly face the challenges of managing this highly morbid disease in the operating room in the coming years. So the key to prevention of perioperative morbidity and mortality in these high risk patients are, we need to identify who are the patients at risk for developing or having diastolic dysfunction, and also having a knowledge of perioperative situation that can exacerbate this disease, that can increase the perioperative morbidity or mortality. And once you know that, we need to know what are the different measures to address those concerns. That is what is going to discuss in the next few slides. So when it happens, what are the etiology of diastolic dysfunction? So we know that diastolic dysfunction is the abnormality in the myocardial relaxation. The most common cause is going to be the myocardial ischemia, which causes, once it sets in, it's going to cause the rate of pressure decline is going to be less. That is, it's going to relax very slowly. So because of that, when the relaxation is little bit slow, it will not be able to generate an adequate transmitral pressure gradient, either because of the elevated LV pressures, or it's because it's not able to generate a good LV suction. Then as the disease progresses, the elasticity of the left ventricle is going to go down. This may be because of the alteration in the cytoskeleton properties, which causes stiff left ventricle, which is going to further reduce the LV compliance. And finally, an external effect like pericardial constrictive pericarditis or pericardial other effusion, something like that, then it can impact the diastolic function. So having said that, what exactly causes the ventricles to become stiff? So the certain conditions like obesity, uncontrolled hypertension, diabetes and COPD, all these things causes an imbalance in and produce pro-inflammatory cytokines. These pro-inflammatory cytokines are the main factors or major factors in causing fibroblasts and the changes in the collagen distribution, which is going to cause these two important components of the diastolic function, that is your active relaxation and passive compliance. It causes the left ventricle to become more stiff and it affects the relaxation. So what is the net effect? So straight line is the normal pressure volume loop under normal conditions, whereas this dotted line is the pressure volume loop of the patient with diastolic dysfunction. So because of all the effects what we have discussed earlier, the pressure volume loop is shifted up and shifted to the left. That is, for any given left ventricular end diastolic volume, the left ventricular end diastolic pressure is going to be on a high. So because of that, greater dependence is put on the left atrial contraction to maintain adequate preload for the cardiac output. So how are you going to grade the diastolic dysfunction? The grade 1, it is the result of an impaired LV relaxation. Most often it happens secondary to left ventricular hypertrophy. Because of that, there is going to be a reduction in the early transmitral pressure gradient, which causes early filling to go little bit less. Because of that, this patient depends on the atrial kick, atrial contraction, in order to compensate for the normal stroke volume. So if you remember this image from the earlier slide, diastolic filling happens at two different phases. The first one is the early filling, the second one is the late filling, and this is a diastasis. Normally, during rapid filling, that majority of the blood flow or the majority of the filling happens during the early phase. But during this grade 1, what happens? The majority of the filling is going to be determined by the atrial contraction. So initial filling is less and the late filling is going to be much more, because this grade 1 depends upon the atrial contraction for their filling. So as the disease progresses, what happens? The LA gets remodeled, and in order to generate the pressure gradient, because it has to maintain the pressure gradient to push the blood into the left ventricle. As a result, left atrial pressure rises and early diastolic filling becomes prominent, just like this. So this is the normal one where the early filling happens, the majority of the filling happens during the early period, then it becomes grade 1, and because the LA gets remodeled and its LA pressure starts rising, it goes back to the normal position. Early filling becomes more. That is the reason why this grade 2 dysfunction is called pseudo-normal pattern. So just let me explain that. During the normal phenomenon, actually LV, because of that sucking effect, it just sucks the blood. Once the mitral open, it just sucks the blood from the left atrium. But during the pseudo-normal pattern, what happens is the LA, because of the increased pressure in the LA starts pushing the blood into the left ventricle. This is the difference between the normal and a pseudo-normal pattern. Then subsequently, as the disease progresses, they move to grade 3 or grade 4, which is called restrictive pattern. So they may be either reversible or irreversible. How it happens is, once the LV compliance, once the disease starts progressing, LV compliance further reduces and early filling is achieved at a very high transmitral pressure gradient. Because the LV is more stiff, the moment blood enters the left ventricle, immediately the pressure in both chambers starts getting equalized. This equalization happens very fast and this is called restrictive pattern. And if this pattern is reversible by certain preload reduction procedures like either Valsalva or nitroglycerin, it's called grade 3. And if it is not reversible with this Valsalva or nitroglycerin load, it's called grade 4. But remember, this both grade 3 and grade 4 diastolic dysfunction carries a very poor or very grave prognosis.